20-year-old man was involved in a street brawl. He swung and missed and struck a wall with his left hand. He had developed swelling and deformity of the hand and was reviewed in 2 days later in an emergency with continuing discomfort despite elevation. The differential can be a metacarpal neck fracture, metacarpal or proximal phalanx fracture, metacarpophalangeal dislocations, metacarpophalangeal joint infections, or sagittal band or extensor tendon collateral ligaments injuries. When you go on further for examination of the patient, when viewed dorsally, the fifth metacarpal head lacks the prominence than the other digits. There is tenderness with maximum tenderness at the metacarpal neck, and palmar palpation revealed fullness at the level of metacarpophalangeal joint. The patient was asked to actively extend his small fingers. The metacarpophalangeal joint hyperextend 5 degrees, but he is unable to fully extend his proximal interphalangeal joint. When the patient is made a fist, the small finger rotates towards a thinner eminence and overlaps the ring finger. There is no open wound. 2-point discrimination test and vascular assessment is normal. The diagnosis was revealed by X-ray, which showed a fifth metacarpal neck fracture with 6-degree apex dorsal angulation and volar comminution. This is the most common mechanism of boxer's fracture. The history, examination, and radiological assessment will help you identify it. When applied to the fifth metacarpal boxer fracture is a misnomer because professional fighters are more likely to have fracture of index or middle metacarpal neck. Breaking the small or the ring finger metacarpal neck is more common, often seen in weakened pugilists who are using poor boxing techniques. The metacarpal neck is one of the most common sites of fracture resulting from a clenched fist blow. The apex dorsal angulation occurs as a result of 3 factors. Number 1, the volar moment arm of the intrinsic musculature flexes the metacarpal head. Number 2, the forces vector causing the fracture is from dorsal to palmar direction. Number 3, invariably there is some degree of volar comminution at the fracture site. Regarding the treatment, while discussing the degree of metacarpal neck fracture angulation which is accepted, the index and the middle finger with the relatively immobile metacarpal joint must be considered separately from the ring or small digits. Most surgeons agree that the index and the middle finger should not be left with more than 10 to 15 degrees of angulation. The CMC joint of the small and the ring finger travels through 35-degree flexion arc, which allows patient to tolerate larger amount of angulation at those digits. The amount of acceptable metacarpal neck angulation from these digits is therefore a bit controversial. Several authors support accepting apex dorsal angulation up to 70 degrees, whereas others tolerate only 20 degrees. Some articles have reported an angulation about 70 degrees, but others have published patient dissatisfaction in angulation which is greater to 20 to 30 degrees, second to the loss of knuckle prominence and palmar discomfort while grasping objects. As a practical compromise, surgeons prefer apex dorsal angulation of a ring and small metacarpal neck of less than 30 to 40 degrees with no malrotation, and small metacarpal neck fracture to be less than 30 to 40 degrees with no malrotation and no pseudocline. Delayed presentation or loss of reduction may necessitate accepting 70 degree of angulation and then treating the rare symptomatic patient with corrective osteotomy. Boxer fractures should be treated with a close reduction if the fracture is still mobile. If it's less than 2 weeks old, the following criteria should be met. Number 1, angulation greater than 30 to 40 degrees in a ring or small finger Number 2, rotation manner alignment. Number 3, pseudoclying. Pseudoclying means metacarpophalangeal hyperextension and PIP extensor deficit. Performing the reduction of the should be done under metacarpal block, or alternatively an ulnar nerve block can be utilized. The most common used technique is called Jahas maneuver. The metacarpophalangeal and interphalangeal joints are flexed till 90 degrees to relax the intrinsic muscles and tighten the collaterals. The metacarpal head is then reduced onto the shaft by exerting upward pressure on the distal head of the proximal phalanx, forcing the base of the proximal phalanx into the metacarpal head. Immobilization methods include either gutter splint or circular casts. Closely molded gutter splint, including an adjacent uninjured digit, required gives adequate immobilization while providing a safety margin of accommodating swelling. Immobilization is best accomplished by placing the wrist in 20 to 30 degree of extension, metacarpophalangeal joint in 80 to 90 degree of flexion, and interphalangeal joint in extension. Radiograph is obtained within 1 week of immobilization to ensure no loss of reduction. Treatment is continued for 3 to 4 weeks. Patient is then allowed to begin active range of motion of the injured hand and wrist. For patient requiring additional support, protection by a removable P1 blocking orthoplast splint can be applied. For an additional 2 to 3 weeks between exercises and at night, do not immobilize the fingers in the Jahas position used for close reduction because of the risk of PIP flexion contracture and skin necrosis. Regarding the surgical management, indication for operative intervention metacarpal neck fracture is number 1, if you are unable to acceptably reduce the fracture. Number 2, re-angulation after the initial acceptable reduction. Number 3, exhibit malrotation following reduction. If the fracture is less than 2 weeks old and still mobile, close reduction with a K-wire fixation under fluoroscopic guidance is an acceptable maneuver. One popular method is cross-pinning technique. 2.045-inch K-wires are inserted across the fracture site from opposite side of the metacarpal head. When using this technique, the surgeon must be careful not to over-distract the fracture site. And the alternate option is to pin the metacarpal head to its neighboring metacarpal. 2.045-inch K-wires are inserted from the fracture metacarpal head into the next closest stable metacarpal head. The third K-wire is inserted between the diaphyses of these adjacent metacarpal for final stabilization. When performing this technique, the surgeon should be careful not to laterally translate the metacarpal head. Numerous other techniques are also possible. Rarely open reduction and internal fixation through a dorsal extensor splitting approach is necessary. Although pin fixation is described previously can be employed for fixation, a dorsal tension band wire loop also works well and avoid potential problems associated with exposed pins. After surgical stabilization, a P1 blocking plaster or orthoplast splint is employed to have protection of the fixation. Active PIP and the distal interphalangeal joint range of motion exercise are started to avoid stiffness. Residual metacarpophalangeal joint stiffness is treated with active, passive, and dynamic modalities in next 6 weeks. Delayed presentation of an open boxer fracture is a contraindication to internal fixation, or all wounds over the metacarpal neck fracture should be considered a human bite until proven otherwise. If the status of the wound is questionable, delayed fixation until the wound and the soft tissue envelope has healed is a good option.